Good afternoon, everybody. It is my pleasure to introduce first speaker. The need introduction, Professor Prakash Singhal. Parag Singhal.
Okay, good start. Always
Good
a good
start.
start.
He's the chair for BAPIO, national chair for BAPIO. He's also chair for organizing committee for this conference. And he's a professor in endocrine in Bristol and has won multiple awards. So he's going to set the scene. He may tell you a little bit hidden message on that, and then he's going to talk about the prudent healthcare in medicine.
Thank you. Thanks, sir. In the interest of the time, I'll start. So this session is about reducing the burden and affordable healthcare. Now, what I mean by affordable healthcare is the healthcare has to be affordable for the state as well as for the public. If the cost keeps rising, at some point, your taxes will go up and it will become unaffordable for you. So this session is all about reducing the burden. So I was supposed to set the scene, but then I thought of a better idea. There is not a better person than Professor Nina Modi to set the scene. She is in Brazil, but she has very kindly sent an audio message, and she is going to set the scene, what NHS is all about at the moment.
Friends and colleagues, I'm sorry I couldn't be with you today. Parag Singhal therefore asked me to say a few words. I just hope my technical skills are up to the task. The theme of this BAPIO conference is waste. We've heard a lot about waste in the NHS and the need for greater efficiencies, and I absolutely agree that this is really important. But let's start on where we should, at the beginning, by considering what are the major causes of waste in UK healthcare today. I put it to you up front that the largest causes of waste are the transactional costs of the internal and external markets that have been imposed upon healthcare in England. These are quite unnecessary. Because, let's take the internal market first, as long ago as 1990, a Health Select Committee concluded that the internal market was an expensive failure. And of course, the internal market has never been adopted in Scotland. The internal market is said to cost some £5 to £10 billion a year. This is a prime example of flagrant, excessive and unnecessary waste. Then there's the external market, savagely imposed upon the country by the 2012 Health and Social Care Act. This made commercial contracting virtually obligatory. Why, for example, is a very large and rapidly rising proportion of the NHS budget being spent on buying services from for-profit companies? And by large, I mean large, because, according to the CHPI, almost £23 billion a year, about a quarter of the annual NHS budget, is being spent in this way, which means that a substantial amount is going into the profit margins of large corporate organisations and not into frontline care. A spectacular number of these companies have failed and then required bailout with public funds. Thus we saw the failure of Hinchinbrook Hospital when it was franchised to Circle, a private for-profit provider, and most recently the termination by Virgin of a £270 million contract for community services. These are eye-wateringly large sums and represent waste on a massive scale. What's been particularly invidious is that the 2012 Health and Social Care Act also permitted foundation trusts to raise up to 49% of their income from private healthcare, while simultaneously NHS public funding has been progressively squeezed. This maliciously has driven the growth in private healthcare by driving people away from the NHS. So, the message is clear. Abolish the internal healthcare market and restrict the external market, and save the nation many billions of pounds each year. Friends and colleagues,
So let's start. So Professor Nina Modi is immediate past president of Royal College of Pediatrics and Child Health and is president-elect of UK Women's Federation and is one of the most influential medical leaders in the United Kingdom. So let's start with the theme, what she has said, what we can do ourselves. Rather than blaming the management, politicians, and the Department of Health, let's see what we can do. So this is a dashboard of health system quality, all red lights flashing. The patients are not getting timely access, safety is being compromised, systems are not efficient, and patients are not being taken into the care. Healthcare spending is increasing, has been steadily increasing, and is expected to reach 150 billion by 2020, but we want more. You continue to pump money in the NHS, we will still want more. So let's see what we can do. And I'm not talking of other issues, I'm only simply talking about what clinicians can do. So let me start with a story. Very simple story. A young lady referred from emergency department to ambulatory care for review of suspected pyelonephritis, which is kidney infection. She had attended emergency department the day before with right-sided chest pain. Important to note, urine dipstick was negative, but she had significant inflammatory response with very elevated CRP and high white cell count. She came to ambulatory care, X-ray was done, X-ray shows a shadow, and given that she had high inflammatory response, the diagnosis of pneumonia was made, and because she was unwell, she was admitted for 24 hours for intravenous antibiotics. Reviewed by medical consultant who requested CT scan of the chest. How many people in this room feel that the request was justified? I suspect no one will say it is justified. We did not do CT scan, she went home, we repeated the chest X-ray in line with good medical practice, complete resolution of shadow. What are the issues here? She had attended ED, urine dip was negative, and I'm at loss to understand, in the absence of positive urine dip, how a diagnosis of pyelonephritis can be made. Shadow on X-ray is always a concern. Whenever we see a shadow on the X-ray, we are worried. But this patient did not have any red flag symptoms, non-smoker. So what's the missing link? The missing link is lack of clinical narrative, joining the dots, thinking, taking a step back and thinking about a diagnosis. What's the evidence of overuse? One of the district general hospitals in Southwest did an audit for CT scans of the chest to look for clot in the lung. The NICE guidelines are very clear that the patient is suspected to have clot in the lung. Physical examination, history, and a chest X-ray needs to be done first to rule out other causes. If clot in the lung is suspected, then Wells score need to be used. I won't go into the details of how Wells scoring is done. 100 patients were searched from the X-ray department who had the scan, and they were assessed through the notes for the symptoms, investigations, and Wells scoring. So the NICE guidelines clearly indicate that Wells scoring need to be done for patients who have got suspected clot in the lung, but in the audit, it showed only 3% of patients had guidelines followed. Yes, from time to time, we override the guidelines as clinicians, but following the guidelines only in 3% and not following in 97% of patients is unacceptable. Is it similar picture across the country? Yes. Just between 3 years, between 2013 and 2016, the number of CT scans have gone up by 33% and MRI 31%. Just in the period of 3 years, forget about last 10 years. But we want more. Looking at worldwide picture, the use in United States grew from 3 million in 1980 to more than 85 million in 2011. We all agree that scans are important diagnostic tool, but FDA reports that 50%, up to 50% of these scans are unnecessary. And a wonderful study in 2009 from Boston revealed, or they reviewed 31,000 patients who had CT scans, and 33% of those 31,000 had more than 5 scans in their lifetime. 5% had received 22 or more scans, and 1% underwent more than 38 scans rather. So why are we seeing what we are seeing? NHS is not a commercial driven sector. NHS is America or India. The consultants don't have any incentive to request for more scans. So why are we seeing? Is it easy availability that we keep coming with new imaging modalities and all we clinicians do is to misuse the system? Is it laziness on the part of clinicians, both mental and physical, that we can't be bothered to take good history, can't be bothered to examine, and all we need to do is to rely on scans? Or is it training? That through our undergraduate and postgraduate medical schools, our training has changed completely, and we are in the mindset of ruling out diagnosis rather than making a clinical diagnosis. If we continue to practice what we are practicing, there are 4 implications: ED, healthcare sustainability, patient harm, and relevance of doctors. So healthcare spending has been going up, but we are still struggling for beds. This is not winter crisis anymore, this is 24/7 crisis. Delays. We talked about ED crisis, winter crisis in the morning. One scan easily takes 2 hours, and a lot of patients presenting to ED departments have unnecessary scans. Imagine a situation where we are not doing these unnecessary scans. You can save 2 hours in the journey of the patient, leading to less overcrowding, less delays. And same principle applies for inpatients, patients who are waiting for diagnostic tests who don't need them. And if we come back to the ED, there are 3 things in emergency department we need to do if we want to address the delays. We need to avoid unnecessary investigations. We need to have better use of ambulatory care, and we need to have integrated model as mentioned by Dawn in the morning. Medicine is a changing world, we all agree. Gone are the days when there was no treatment for stroke or myocardial infarction. Our interventions are effective but potentially dangerous. We are now giving anticoagulation to 90-year-old who can present with intracerebral bleed. Our population is not getting any healthier. All the more reason for doctors to use the clinical skills. Sustainability. It's always going to be finite resource. You're never going to have a money tree. And we need to utilize the money properly. And in the morning we talked about, it's not about how much you spend, it's about how you spend. And I pose a question, do we really need more money? And my view is well known. I don't think so. We need to spend wisely. King's Fund have quoted that if we practice good medical medicine, we can save up to 2 billion. Yes, in big scheme of things, 2 billion is nothing, but every little helps. And at some stage, our intervention is almost causing harm to the patient. Let's see how. An average CT scan may be associated with the increase of fatal cancer of chance in 1 in 2000. 1 in 2000, one scan. Studies published in 2007 and 9 by Columbia University predicted that up to 2% of future cancers, 2%, 29,000 cases of cancers and 15,000 deaths annually might be caused by scans. Compare this with risk of anesthesia, 1 in 100,000. What do? We take patients into confidence when we anesthetize. We take their consent. We run the risk with them. But do we do with the scans? No, we don't. Because with anesthesia, it's an immediate harm. But with the scans, it's a long-term harm. I'm not even going to talk about contrast nephropathy. Now, I will apply for the benefit of sick and all measures required, avoiding twin traps of overtreatment and therapeutic nihilism. Then that's Hippocratic Oath. The primary responsibility of a physician is to do good, not to do any harm. Final point. Why do we need doctors? We go to medical school, we spend 5 years in undergraduate medical training, 9 years as postgraduate before we become consultants. And that training is all about learning, applying the science, applying the knowledge. And if we have decided that we don't want to apply the knowledge, then my question to you is, why do we need doctors? Why do we need to spend billions and billions of pounds in training to doctors? Anybody can practice medicine if we just have to do the scan. We need to stop this epidemic. We need to do something about it. Patient safety is not about more money. Patient safety is not about more doctors. Patient safety is about robust decision making, timely decision making. And time has come for medical profession to introspect and see what we can do ourselves. I don't believe we need more doctors, but even if I concede that we do, I think we need thoughtful doctors, not just more doctors. We need to start a change, and this conference is about starting a change, going on a journey, and we need from planning to experimentation phase. And my next speaker will describe how. So, thank you.
Thank you very much.
Parag, thank you so much for a fantastic talk. I think you're bringing the message back. We are losing the clinical skills. We are depending on investigations, and we are Americanizing our, training. So thank you. That's an important message. May I invite Mr. Sachit Mehendale? Okay, sorry.
That's okay.
Eric Catling, he's Executive Director for Transformation for North Bristol Energy Trust, Hertfordshire.
Thank you. Thank you very much. Can everybody hear me all right? Yeah. Thank you. My role is leading programs of work in North Bristol, and my kind of role can be summarised in 3 things. One is helping people turn ideas and opportunities, helping them identify Secondly, turning those ideas and opportunities into reality. And thirdly, then seeing through into delivery. And I know Dr. Parag Singhal for a number of years, having worked together previously in Western, and when I heard the work he was doing around looking at CT investigations, my instant reaction is, we want some of that in North Bristol. So we spoke and we came up with an idea for a programme of work, really to get a group of interested clinicians from different hospitals looking at CT investigations. And, you know, the evidence is already very clearly spelled out of why we wanted to do that. And effectively, what we want to do is tackle a range of different issues. So they're the kind of aims that we're looking for, not just, obviously, to save money, but to look at the broader impact on care, impact on patient pathways, and actually have a product that we can then take forward and share wider than just the small number of hospitals that are working on this. So, we've got a little bit of interest so far from 6 hospitals. At this stage, it's still emerging. We're still having the ongoing dialogues, but we've got a commitment to move forward in this particular area. And what we're particularly looking at is different hospitals working on different parts of the CT pathway for different parts of the diagnosis. So if all of us work on exactly the same, we'll get the same results, where you need to look a little bit more wider. And what we try to think about is how are we going to do this? So rather than just build a program from scratch, many of you will be aware of the collaborative methodology that was quite big probably 10, 15 years ago around change programs. And very recently, the Health Foundation published a meta-analysis of collaborative programs around the world. And effectively, when I sat down with Parag, it was very clear that actually all of their key 5 recommendations about collaboratives were exactly what we needed to do. So effectively, we are designing a program that's going to work across those hospitals that we've already identified, working in a very systematic way. We're looking very much at the specified clinical topic, and what we're allowing each hospital to do is pick the areas they're working on. So already we've got a bit of interest, in particular looking at scans for CT heads in A&E. We've got some interest in scans for patient in the cancer pathway. Particularly in North Bristol, we've already started an internal dialogue between our clinicians and managers around particularly those scans that are last minute discharge-dependent patients. You know, how many patients do we say can't go home till they've had a scan? Do they really need that scan? Is that scan critical for their discharge? And the other area, because North Bristol's a specialist teaching hospital, we get a number of referrals from other parts of the region, and the first thing we do is we rescan them. How can we get better at image sharing and information sharing to actually avoid duplicate scanning, which not only exposes the patient to unnecessary radiation, but adds extra time to their overall journey. So that's what we're trying to do. This is the next steps. At this stage, we're just in the process of establishing the steering board and the governance. We're finalising who's going to do what. We're setting up the first learning event in December, with a number of other events coming up subsequently over next year. And then the idea is that we'll link in to other professional bodies, other interested organisations. This we can't do in isolation, but we're kind of starting a movement ground up. Thank you.
Thank you very much, Eric Gatling. It's a very important point of collaboration. We have sort of embarked on similar clinical scenario in Royal Free Group of Hospital looking at VZ pathways across so that the patients do cross across different part of the hospitals, and I think collaboration is way forward. My next speaker is Mr. Sachin Mendele. He is the organizing committee chair for secretary for the Bristol conference, and he's trauma and orthopedic consultant surgeon Bristol.
Thanks, Arvind. Thank you very much. So, continuing with the reducing our cost burden theme that Parag proposed, we'll look at procurement in the NHS and how we can try and rationalize what we use and look at the costs. So, what does procurement mean? The Oxford English Dictionary talks about obtaining something with care or effort. Okay? This is what it translates in the NHS, a lengthy document with about 13 sort of indexed pages. This is just a background of how many joint replacements we do. This is data from the England and Wales National Joint Registry. So about 100,000 plus hip replacements and 100,000 plus knee replacements. If you imagine we even managed to shave off about 10 pounds of each of these, look at the amount of individual savings that we would achieve. And we can do it. It's been done before, and we'll try and do it again. So why is it important? Because we use a variety of expensive implants. Orthopedics is an expensive specialty, especially where more and more elderly patients. It accounts for a high non-pay burden. Okay, so just to give you an example, I split my work between the BRI and North Bristol Trust. So between the two hospitals, the combined budget for just primary hip replacements, last year we spent in excess of 1 million. Okay, just to give you an idea. And then the National Joint Registry, which is again the sort of where every single joint replacement in these two areas is recorded, reports 822 different combinations of cup and stem. Okay. This, I know you can't read busy slide, but it's just the cemented prosthesis that we use. This is just the stem, so one bit of the hip replacement. There are about 40 different types that we're using when we know that there are some time-tested ones which are cheap and give very good results. So there's a huge variation in average prices paid by individual trusts. Depends on the volume, yes, but in some cases, we don't quite know why it's costing that much. So primary hip replacements, the cost in England varies between £800 to about £2,000. And similarly, with knee replacement, it costs between £1,000 and sort of £1,900. If all of these trusts were to pay an average price for their implants, then each individual trust would save about £56,000 per year. If we then manage to get all trusts to get the best price that is available for that particular device, we would go in excess of 220,000 a year. So massive amounts of savings. And this is where it changed. So getting it right first time, it's coming in sort of surgical branches, certainly started in orthopedics, Professor Tim Briggs' initiative. And it talks about quite a few things, but it was mainly about adult elective orthopedic services. And the one statement that was important there is that the surgeons need to be aware of the cost implications of their decisions. Okay? I was at our sort of national meeting recently, and somebody put up a slide of this. And the sort of feeling was that orthopedic surgeons in the medical fraternity are sometimes perceived as this. So thick-skinned, sort of slightly dim, and ready to charge wherever needs be. We tend to think of us more like this. Just a kid in a pick and mix sort of shop, and there are so many toys. I mean, we can choose whatever we want. And the more expensive surely must be better. Maybe not. So the problem here is there are too many suppliers. Although the market is dominated by about 5 big companies, there are quite a few smaller suppliers. There are too many people involved in the procurement process. The implants themselves are expensive. And there is erratic decision making, despite good evidence to the contrary. Like I said, the cheapest thing might actually be the best. Now, this was work done by my colleagues, Jason Webb, Stevie Stavering, along with the then general manager of our department, Simon Setti. And what I would like to sort of bring to attention, that GIRFT initiative and the implant pricing published by the National Joint Registry was 2013 and 2015. This initiative started in 2012, or it was presented and the work was done. Okay? So, very simple strategy, 3 goals: have the best evidence base to provide high quality hip replacements in patients. It is practical and meets surgeons' demands, i.e. keeps everyone happy, and deliver savings of at least 15%. Okay, so that was the target set. And they did it. So at the time, we were losing money on every single hip replacement we did. So about loss per hip of about 22% to a profit of 8%, and nearly £230,000 saved off our budget. Okay? Now, does the work end there? So this is where now the National Joint Registry has picked up. So we have 2 things. Inform and Embed are 2 programs. Inform is your sort of basic service, which gives you basic implant price benchmarking. And the Embed is the sort of more platinum service, where you get more sort of trust level data, how much. So if we look at individual data, I as a surgeon can see how much I've spent on prosthesis and how much they cost. Okay? So, and I can decide whether the sort of cost is justified, essentially. So we were about to run out of tender in 5 years' time, so from 2012 to 2017. So at that point, we were not in a position to go through with the tendering process. So what we did was re-engaged with the companies. Okay? And it's important to do it, so it's not a done deal. So there are plenty of opportunities. We looked at just primary and revision hip portfolios. We extended their contracts. The carrot was that they might get more business. The stick was that they might lose it completely and they might be kicked out of the department. Now, the price was renegotiated, and this is what we managed to achieve last year. So they were projected savings, but I'm pleased to report that we've actually managed to achieve this year. So from supply, we have sort of, in the 2012 procurement round, we narrowed it down from about 7 suppliers to 3 suppliers. And now here, we've managed to shave off another 100,000 of all those companies' prices that we had. The next round of procurement is in process at the moment, and the important thing is clinician engagement, because if you see all the varieties of implants, it's very hard for the procurement guys to make out, well, you need to put a stem in, then need to put a head in, then a socket and a liner and all sorts of things. They would have no idea. So you need to be there to sort of guide them through the process and lead the process if needs be. There's a collaborative consortium now, so Bristol and Western NHS Purchasing Consortium. That gives them greater power to negotiate because they could lose business across all 3 trusts in the region. The industry engagement has to be with clear rules and it has to be transparent. So there are no sort of wheeling dealings going on. It's all above board. And quality and patient safety has to be paramount with all of this. So look at the evidence. And my take-home messages to you are that clinician engagement and leadership is essential. It has been done before and it can be done. Transparency and clear set of rules, and most important thing, evidence-based decisions, National Joint Registry data. It gives data on longevity of joint replacements. It's all there. And the orthopedic data evaluation panel. So this assesses the quality of evidence and the studies and then rates them sort of 3, 5, 7, 9, 10 according to the number of years, and A, B, C according to the quality of data. So it's all there. And you need a committed management team behind you who, it's in their interest, but they still need to be engaged in the process. And this is where when the clinicians, procurement teams, and the directorate come together, you will achieve massive savings. And I would say to you that it's not about obtaining something with care or effort, it's obtaining something with care and effort, and it can be done. Thank you very much.
Thank you, Sanchit. There's so much hidden money in procurement, and working with the team and rationalizing what joints you're using and things is very important. My next speaker is Professor Keshav Singhal. He's here. He's MB and he's orthopedic surgeon from South Wales. He's the chair of BAPIO Wales and executive board member of Welsh Medical Committee. He pioneered the introduction of joint school and enhanced recovery in Wales, and is champion of the prudent health care. He'll be talking about healthcare in surgery.
So I hope you're all out of your slumber with that brilliant presentation by Sanchit and Parag and Eric. I'm going to talk about Prudent Healthcare, which is a flagship program of Wales, NHS Wales. When I first come across this program, I thought this is a very lofty program, and it took me quite a while to understand. But when I distilled it down into basics, there are very simple 4 principles. Do no harm, do whatever we have based on evidence, do it only if you're skilled to provide that intervention, and make sure that you're providing value for money. So I think on the face of it, all 4 are very simple principles. And I would put it to you that if it is prudent, then it is also affordable. And this conference is all about making sure that the healthcare we provide is affordable, not for the state, but also for all of us as taxpayers. So co-production, I thought, well, we're not into a movie set where we're producing a movie, but co-production basically is that whenever you do an intervention, you discuss the intervention with the patient and take into account the patient's wishes and not be paternalistic and not say, oh, I'm a doctor, I know best. Secondly, triage. We all know triage. So in other words, we have finite resources and we have to care for those who are in the greatest need of health care compared to relatively trivial interventions which may be more cosmetic. Thirdly, do what is needed, no more and no less. So do not go for unnecessary, unproven interventions. And finally, do whatever you have to do based on evidence. So I'll take a few examples. So we've got an 80 years old female who has an arthritic knee. The pain is manageable. The patient comes to me and I say, you should have a knee replacement. The patient is reluctant because she says, I can manage. But being the doctor or surgeon I am, a bull in a china shop, I said, no, you must have a knee replacement. And I give her a knee replacement. Well, predictably, the patient is unsatisfied. A, her pain wasn't bad enough, and B, she was reluctant to undergo surgery. So even though the surgery goes well, she still has some pain. She is an unhappy patient. An unhappy patient can lead to litigation. This is not prudent health care. We've got a 50 years old female with 145 kilo weight recorded on the first consultation. Right advice given, please reduce your weight and come back in 9 months. Comes back, weight increases rather than decreases. What do? You go ahead, or do you say to the patient, well, you know what, you need to take some responsibility for your well-being. You know, we don't have a magic wand. We are clinicians. We are not miracle workers. But do we have the courage to have those difficult conversations? But that is very much a part of prudence in healthcare. Co-production. On the flip side, 90-year-old chap, wheelchair-bound, totally blind, with 2 arthritic hips and 2 arthritic knees, wants all 4 joints replaced one by one. So I asked him, what are you going to achieve out of it? Are you in pain? No, I'm not in pain. So if you have 4 joints, are you going to be able to mobilize? No, I'm totally blind, I can't mobilize. So what are you going to get out of it? Well, I want it replaced. So I said, sorry, I don't think this is in your best interests. So what happens is a week later, a complaint lands on my desk saying the patient has, the doctors refused to treat me. Fortunately, I had referred that patient to Ivory Tower, and their opinion was exactly the same. So co-production has to be sensible. You can't be swayed just by patients' wishes, even though they may be completely unreasonable. Triage is very simple. It is obvious to all of us. We do it every day. And it is basically a simple thing saying, if you've got a big health problem, you give priority to that compared to procedures of limited clinical value. And there are a number of those. For example, a lot of hospitals in the NHS have stopped treating bunions because that money could be better utilized in doing something else. From my point of view, a prime example of this is knee arthroscopy in a degenerate knee. There's a plethora of evidence out there to suggest that a knee arthroscopy in a degenerate knee does not give good results. It's a placebo effect maybe for 6 months or 12 months, and the patient inevitably comes back. So why do we still persist in doing that? Do only what is needed, no more and no less. So this is now a classical example of law of unintended consequences. We've set up this all shining, all dancing, singing, musculoskeletal clinical assessment service. This is available all across the UK. And this is a typical pathway of what happens. Patient is sent by the GP to the service, has an MRI as a first step investigation. Clearly the MRI will show some subtle abnormalities because it is very, very sensitive. So the patient has an injection, no better. Physio, no better. Further injection, no better. Referred to surgeon, has an arthroscopy, no better. Chronic pain referral, no better. Why? Because we did not manage that patient's expectations right from the beginning, and we medicalized her trivial symptoms. We made the patient believe by doing an MRI and saying, oh, we've got something on the MRI, that there's something wrong with the patient. As a result, those feelings have been embedded in her brain, that there's something wrong with me and I need an intervention to put me right. Of course, you're not going to get better. Parag has already talked about CT chest, and this is something we see very commonly. Simple cough, CT is a first-line investigation. And if they are giving meropenem, for God's sake, can that be right? No. I mean, this is an example from St. Elsewhere, other country. That wasn't prudent medicine. So we are relying needlessly on investigations and perpetuating an illness behavior. This is a classical case, again coming back to knee arthroscopy of a middle-aged person with a mildly degenerate knee, with a degenerate tear of the meniscus, has an arthroscopy. Evidence is coming out that when you do a meniscectomy in such a patient, you actually take away the remaining cushion between the arthritic bones. And that arthritis progresses very rapidly, leading to a much earlier total knee replacement. So we have done an unnecessary arthroscopy. We have accelerated that patient's wear and tear, and we have probably given a knee replacement much earlier than would have normally been needed. The third principle is to reduce inappropriate variation. Now we've got various trusts in the same region with hugely varying incidences of doing an intervention. And again, coming back to orthopedics, because that's my trade, shoulder impingement, there's enough evidence to suggest that in most cases physiotherapy will give as good a result at 1 year as a surgical intervention. So why have you got huge variation? Clearly somebody is not applying the available evidence prudently. So those of you who are Rotarians here would probably know or would have heard of the 4-way test. And I propose a 5-way test for any medical intervention. The first thing is, does the patient need that intervention? And is the patient ready to have it? And I can tell you a third of the patients would be filtered out at the GP referral stage if the GPs apply that test. Because a lot of patients come to me and say, oh, I don't want an operation, but I thought I'll just come and have a chat with you anyway. Number 2, is that intervention going to improve either the patient's longevity or the quality of life? If the answer is no, the surgeon has no business of proceeding. Is the intervention evidence-based? And whatever implants we are using, have they got the requisite track record? And is the implant providing value for money? So hip replacement costing £400 with 20-year excellent results gives the same result as a 2-year-old hip replacement costing £2,000. That's not prudence. This is very important for the operator or for the surgeon or the physician. Have I got the requisite skills to deliver that intervention in a safe manner? Am I the best person to do that? And finally, from the patient's point of view, am I managing the condition of the patient or am I managing the patient's expectations? So you cannot practice medicine based on their expectations because that will inevitably lead to a very dissatisfied patient and litigation. So that is in summary a very brief overview of the prudent healthcare, and I think we can all apply it in a small way in our clinical practice in every day. Thank you very much.
Thank you so much. Professor Keshav, thank you very much. We should think about this 5-way test. Very important take-home message. Now, may I introduce Thanka Tubener, Labour Member of Parliament for Bristol West since 2015. She previously worked for many years in domestic violence sector, and I understand you're a professional musician also. She is a shadow whip with responsibility for shadow health team, and her political interest is supporting refugees and asylum seekers. May I introduce her? You're going to give apologies for it.
Well, this is intimidating. I'm in a room full of physicians of Indian origin. I come from a family of physicians of Indian origin. I just started counting and I stopped at 10. And so in their eyes, I'm a failure. I've just become a politician. They're all terribly worried about my soul. My great aunt, who is one of my role models, who trained in the 40s in Madras Medical College and set up her own practice, has always been a role model for me, and I know she thinks of me as someone to worry about rather than for anything else. She says, I pray for you a lot. And I'm here because I think that as there are only 9 doctors in Parliament, for understandable reasons, scientists say to me all the time, why aren't there more scientists in Parliament? And I say, do you want to be a member of Parliament? And they go, no, why would I want to do that? And I'm sure that that's the same for all of you. Why would you want to be a member of Parliament? So 9 people did decide to be members of Parliament. There are other clinicians as well. So we as members of Parliament have to rely on all sorts of different and very subjective sources of information. We try to be evidence-based. We try to be well-briefed. I am, for instance, the chair of an all-party parliamentary group on children, teenagers and young adults with cancer, but I've done that partly out of my own interests. I do that based on briefings that I'm given to, that are given to me by different NGOs as well as clinicians. Sometimes those briefings may be good, sometimes maybe they're not. This morning, I'm also the co-chair of the all-party parliamentary group on breast cancer. I'm a breast cancer survivor myself. Some of you in this room are responsible for my treatment, thank you. And I am reliant very often on the briefings of NGOs who don't necessarily have an objective view on what I should be campaigning for. Which leads me to question some of the things that they give me. So for instance, there was you may have heard this morning on the Today programme, big news headline about how secondary breast cancer sufferers don't all get a clinical nurse specialist. From where I sit, I'm more worried about the shortage of radiologists and radiographers than the shortage of CNSs. I had a very good CNS, thank you North Bristol, but that wouldn't have been my primary priority for third headline on the Today programme for breast cancer. So I think there's a sense in which as politicians, I'm here partly because I want you as clinicians to know that we need you if we're going to make sensible decisions. NGOs, the cancer sector for instance, which I liaise with a lot, they employ people to be full-time lobbyists and they're going to lobby their point of view. So Breast Cancer Now will lobby me till the end of time about CNSs for patients with secondary breast cancer. And they may have a point, but is that necessarily the best use of the NHS's money? And I'm not sure, to be honest. Though I would defend the existence of CNSs, I think that there are other ways that we might want to think about what's a good use of political time and thinking about how we spend the money. So, as a Labour politician, I could give you the Labour Party position. I'm actually quite a lowly member of the health team. I'm a Labour whip, a very misunderstood and mysterious role, and I whip the health team, the DEFRA team, and the Department of Environment, Food and Rural Affairs team. And as an MP at the time of Brexit, that means that most of my attention at the moment is taken up with the DEFRA part of my work, because there's any number of things to do with Brexit there. But our health offer is still evolving because we aren't, whatever anyone likes to say, we aren't going to have a general election anytime soon. So Shadow Secretary said, I know some people say different, I'll probably get into trouble, but we're not going to have a general election anytime soon. So our Shadow Health Secretary, Jonathan Ashworth, he's focused on what do we want to do in government, and I'm not going to give you loads of headlines now because I don't think that's the right time. I just wanted to give you a perspective as a politician, not necessarily as a spokesperson for the Labour team. All politicians want to save public money. It's why I'm here for this session, in my view, is we all want to save public money, partly because we want to do more stuff. We have different ideas, and that is related to our parties, about how we should save that public money. But I don't know a sensible politician who doesn't want to save public money. Even if in the health service it's just so that we can treat more patients with better treatments and have better outcomes. So the challenge we face as politicians is the public aren't always quite in alignment there. Again, all the members of the public that I meet, most, not all, would say to me, you shouldn't spend so much of my tax. In fact, why am I paying so much tax? There are some in my constituency who say, actually, I think you should tax people more to spend on the health service. Do you want to pay more in tax, I ask them? Well, no, I think you ought to tax the richest people more, not me. So there's always that disconnect. Something needs to change, but it's not me, as the cartoon said. So I think whilst the public understand in theory that we should be trying to be efficient with public money, and as politicians, I'm really passionate because I think it's my duty to be responsible with public money. I'm a taxpayer as well. I think that there's a disconnect sometimes, and that often ends up on my caseload perhaps in your complaints caseload, but also my caseload, where a disgruntled person will come to me and say, X or Y clinician didn't do what I wanted, it had this or that impact, I want you to fix it. I want you to make it better. And some of the time, that's a really good illustration of the fact that the politician's caseload is mostly insoluble, intractable problems that are not the presenting issue. Someone comes to me and says, I don't like what my doctor did or didn't do, and actually what's usually behind that is some other story of something else that's going on in their life. My job is to try and help that not end up holding up your work by helping to manage their expectations and deepen their understanding. From a political point of view, that's often challenging because you're telling the voter, I don't agree with you. Most politicians try and avoid doing that as well. But I think we have an example to set. So I've tried to use my role as an MP, in the last minute I'll tell you what I've tried to do, tried to use my role to focus on the potential I have, because I get to be on panels, I get to go and talk to school children, I get to go and meet all sorts of people, and for good or ill, people do occasionally listen. I've tried to use my role to pursue certain campaigning issues on health. So one which is very dear to my heart is reducing the harm caused by alcohol. I work closely with the Alcohol Health Alliance. I made myself slightly unpopular with my colleagues earlier this year by doing a big interview with the Observer magazine in which I said that all the House of Commons bars should be turned into gyms. That didn't go down so well. But quietly, lots of MPs came up to me and said, that article made me think, I did not realise that alcohol caused cancer other than liver cancer. I didn't know it caused breast cancer till I had breast cancer. So as an MP now, I feel very passionate about saying to young people in particular, your alcohol consumption will have an impact. So we can use our influence for good. Here's some things that I think you can do to help us. And that's where I'm going to finish. We need you to tell us what you think, what you know, and what your ideas are. If you don't already talk to your local MP or invite them in, do. Some of you in this room who are local clinicians have done that to me. I mean, the reason I'm interested in particularly in alcohol harm was because not only of breast cancer, but a visit to the liver ward up at BRI. And that's just because the person on the liver ward invited me. It could have been something else. So invite your politicians in. Tell us your ideas. Let the Health Select Committee know what you think they should be looking into. They have statutory powers to scrutinise the Secretary of State for Health. Liaise with the relevant all-party groups. We don't have statutory powers, but we can be a position of influence if we're well informed. Make that contact if you don't already. Don't assume that MPs don't want to know. In fact, we rely on you, because we're not experts, most of us, we rely on you to tell us what it is we need to know so that we can save public money on the NHS, treat more patients and have better outcomes. Thank you very much for listening, and I'm sorry I can't be with you this evening.
Hi, may I introduce our guest speaker, Professor Dhananjay Sharma. He's a guest speaker from India. I think you heard him yesterday. He is head of department, Medical College Surgery in Jabalpur. And he has been instrumental in pioneering low-cost surgery, focusing especially on global surgical techniques. This morning I was having breakfast with him and I was asking about his work. And he said he was invited to Stockholm and they said how they can save 10% of budget, health budget from in Stockholm. And he said, don't worry, I'll tell you how I can do all that in 10%. So that's it. Go ahead.
Thank you very much. Yesterday I shared my thoughts on low-cost innovations in medical health and basically the last mile challenge, how to deliver low-cost technology. So today I'll share the roadmap for low-cost innovations. I have a 10-point template. You can call them 10 commandments or roadmap or road signs. First of all is you have to get inspired. I know many bright boys, they get disheartened, get frustrated, and sort of stop working to the best of their abilities. So how do you get inspired? Very few surgeons have received Nobel Prize. The last one to receive Nobel Prize for a surgical procedure was, of course, Professor Murray for a transplant which he did more than 40 years ago, almost 35 years ago. and a plaque on his desk read, "Difficulties are opportunities." So I think it's a wonderful quotation to remember. Every difficulty is an opportunity, and we can rise to that challenge, get inspired. I am privileged to have a mentor, Professor Len. When I asked him, I'm working in low cost, low resource environment, how should I proceed? And he gave this beautiful answer to me that I have to create science, he said. You have to think out of the box. He called it creating science. He said, if I'm playing music, I have to write music. I don't have to copy music, I have to write. And the book of chemistry, he said, because he's a Nobel laureate in chemistry, is to be written rather than read. So we have to go out of our way to do more. So the second commandment would be, we have to innovate and develop appropriate technology. When I speak of appropriate technology is something in which I am involved in its creation. I have to understand what it is. If it is like a parachute dropped onto me, if something goes wrong, I can't repair it. So I have to be involved in its co-creation. I have to understand A to Z what that technology is. That is the appropriate technology because it is low cost for me. And why innovate? We all know, because innovation leads to quantum change. So this is what I wanted to tell you about. The appropriate technology is, it has to be need-based. Till today, in 38 years of clinical practice, no company has ever asked me what technology I want developed. They all come and tell me what I need. Imagine. Unbelievable. Unbelievable. So no one asks me. It has to be available at grassroots level. Thank you. It has to be available at grassroots. It has to be cost effective. It has to be easy to maintain, so I can maintain it, or my technician can maintain it. Technology has to be transparent. It has to be understood by us. We have to be involved in its co-creation, and finally, should be transferable. Easy to learn, easy to teach. Okay? So the next commandment would be, do research on something which is important. Given the chance, I would love to do a cardiac transplantation in the morning, and in the afternoon, I'll invent the vaccine to stop all cancers. Really, this is my dream when I started. Okay? Can I do that? I don't think so. So I go back again to a Nobel laureate who said that you can do research on what is important or what is interesting. So what is important for us is, as I have shown, peptic perforations, enteric perforations, all these things. That is important. So I have to focus on them rather than dreaming of, today I have not done the cardiac transplantation, things like that. Okay? Next commandment would be, get curious about new ideas. When you're working against odds, you really do need good ideas. And this advice again comes from the only person who got Nobel Prize in 2 different science subjects. And what she said was, be less curious about people and be more curious about ideas. Yesterday also I referred to this. Whenever I find young people discussing something, I always ask them, what are you discussing? Sometimes they are discussing about rock stars, film stars, all those people who are selling things to us. They are not doing anything constructive. They are selling something to us, or they are discussing events. I think we should train our scientific minds to discussing ideas. And when you are brainstorming for ideas, your judgment should be suspended. And why not play the role of angel's advocate? Everybody is ready to cut your idea to ribbons. Useless idea. Of no use. Dump it. Don't waste my time. If a young person comes to you, at least give him the chance. Play the role of the angel's advocate. Try to find the good in that idea. And tell your young people to think with their right brain. You know we have 2 brains? I have 2 brains. Okay, right side and left side. Right one is fertile. It's for imagination. Left side is for logic. 2 plus 2, 4. The right side brain says 22. Why not? So let's imagine. Okay. And this is a typical brainstorming session which we hold in our department literally every time we have time. Every time. We have idea makers. We have people who are doing research. We read A to Z everything from anatomy, physiology, pathology, everything. Then we bring tons of enthusiasm in that we will solve this issue. We will. That is needed. So what we do is we think differently, deliberately. And that is how some of these ideas we have been able to some of our ideas have succeeded. I'll give you the analogy of chess. You move a pawn forward, it gets sacrificed, but sometimes it may set up a winning move. If I keep on pushing that pawn to the end, what happens? That becomes the all-powerful queen. And those successful ideas were the ones which I shared with you yesterday. Finally, that pawn reached the end, so that became successful. When you have so many ideas, how do you recognize a good idea? Anybody remembers this picture? So many people saw the apple falling, but it was Newton who discovered the law of gravity, because opportunity favors a prepared mind. So many times it has happened to me also. My idea while I was thinking couldn't go through with it, somebody else published. We all read the same books. We all read the same books. After all, we all have similar ideas. Okay? Peter Medawar, father of immunology, what did he teach us? New idea is like a strong antigen. Your body is designed to reject it. Unless you keep your mind open, you will reject a new idea. That is very common. And then you have to learn from everyone. How does science progress? By two ways. Either you invent or discover something new, or you apply an idea borrowed from another field to your field. These are the only two steps. This is how science progresses. Okay? So, I go back to our first Nobel laureate, and what did Guruji say? Let noble thoughts come from all sides. Don't block them. Ideas are raining. Just keep an open mind and you learn something every day. Okay? So, the next commandment would be look for simple solutions. So, that has become our motto. We don't complicate issues. Okay? We try to modify, simplify and apply. No complications. Anybody remembers what Occam's razor is? Occam's razor? If there are many solutions to a problem, the simplest one is the most likely one. Remember Occam's razor? I am sure you have read about it. And what did our favorite Nobel laureate say? When the solution is simple, God is answering our prayers. So, I have been very lucky, some of our simple ideas have worked. And what did Da Vinci say? Simplicity is the ultimate sophistication. Da Vinci is in the back, guys. Don't get confused. Okay? So, I'm coming to a close. Learn from your failures. Everybody has been taught this from our childhood. My favorite scientist is Thomas Edison, who was the inventor of the last century. So many patents. He invented the light bulb after 1,000 attempts. And his friends used to rag him, you have failed 1,000 times. And what was his response? I have not failed. I have learned so much. I know 1,000 ways by which a light bulb does not work. So, ladies and gentlemen, I know many ways by which surgery does not work. I have not included those in today's narrative because it will take me more than 2 hours. Too many failures, but I learned from each one of them. Now, this is something I have included because somehow an impression was created that we don't have very stringent regulations. Let me tell you, this is the most difficult job when we are trying to innovate. Because usually the head of the institutional ethics committee is somebody from another university or another college, maybe some other department, and I'm not the most popular person at times. So sometimes he had a needle in for me and he doesn't approve. So we go back to basics, do animal experiments, dissections in the cadavers, and then finally sometimes the innovation is easier than getting the permission. But this is a must. This is safety for patient and safety for me as well. And finally, as you already know about me, this is the code of honor for me, for my heart. Okay? Everybody talks about value for money. Just now, even you mentioned value for money. I think we have to aim for value for many. This should be the focus of our innovation. Billions of people are surviving on less than a couple of pounds. So, what do? Ultimate spiritual award is that we include these people who are excluded. We include them in our research, we include them in our innovation. So, this is our obligation to work for people who are underprivileged, who are less privileged than us. And how do we do it? gracefully. I talk on global surgery in many places. I always tell it to them, when you go and try to help someone, do it gracefully. Don't patronize them, don't be condescending towards them. They don't like it. Nobody likes it. Nobody likes it. So, because to lead is to serve, not to rule. Thank you very much.
Professor Sharma, we know why you are king of surgical jugaad. This is the innovation. Thank you so much.
Amazing speakers. I feel like I've learnt so much. I've been to so many conferences. In fact, I think I've been to 3 this week, and this is the first time that I've heard that so much action is happening to help the NHS. I think we always hear lots of ideas, and it was really nice to hear from our speakers that they've translated this into amazing action. Our next bit of the programme is moving on to the panel discussion. I'd like to invite Ms. Thangam Debonair back onto the stage, please. We're also joined by Martin Stegel, and he works at the University of South Wales as the Pro Vice-Chancellor of Research and Dean of Faculty of Life Sciences and Education. And we're also very lucky to be joined by Prof. Dame Parveen Kumar, who needs no introduction. We all have her textbook. Certainly helped me get through medical school, but she also is Professor of Medical Education at Barts in the Royal London. So thank you very much to our panel for coming up, and we are looking forward to your questions.
Hello friends and colleagues. Again, whilst the panel is assembling, if we could go through the poll, which I think many people are enjoying, and I hope the people who haven't joined in just focus your cameras on this QR code and you'll get a web page to join us. And then we'll hopefully be able to show what you think. So the questions we have, and I'll just start it right now if it's okay. So do you feel there is wastage of resources in the NHS? I think it's a pretty direct question. That's excellent. I think it's great, okay. I think we've got reasonable votes. I think it's overwhelming. We don't need to wait too much on this. I'll go for the next question. Coming up now. So do you feel measures to reduce waste should be in place before investment? I think you had speakers mention about this. What do you feel about it? So do you feel you should first stop wastage before investment? Excellent. I'll stop that there. Go to the next question. Do you feel there are significant barriers to implement the initiatives to reduce burden in your areas of work? And hopefully this will create a ground for discussion. Okay, great. Thank you very much. I think I'll let the panel discussion start after this. Thank you.
Okay, so we'll throw the questions over to the floor. I can see one hand here. Please let us know your name and if there is a particular person you want to direct the question to. Thank you.
My name is Mesh Prabhu, Medical Director. I've been Medical Director for 15 years. I've been saying for 15 years that NHS wastes a lot of money and we can save £29 billion. out of 128 billion we spend in NHS. My book is getting ready, author is here, it's going to be published. Parag, thank you for inviting me. It's one of the best meetings I've attended. For the last 15 years, I've been telling everyone, Wigan be transformed within 8 years. It was a nurse-led bullying culture. Mr. Andrew Foster's name has been mentioned 3 times today. It was a nurse-led bullying culture. I appointed right leaders with right values, like one who was sitting there this morning about Arvind and all, and we transformed the trust, reduced harm by 90%. I've been called many names in my life. My value comes from my grandma, Mahatma Gandhi, Nelson Mandela, Martin Luther King. I'm hoping to write 5 books about my life. 75,000 patients suffer in our NHS, moderate to severe harm due to medical error, and we waste 20 to 25 billion pounds. The medical legal bill alone, if we don't get our act right, is 20 billion a year. I've really enjoyed this presentation. Absolutely fantastic conference. But we doctors must take on leadership role. If you always do what you always done, you always get what you always got. NHS had administered leadership, then came management leadership. Now we got real leadership. As Dhananjay said, leader and being a doctor is serving humanity. That's all it is. But unless doctors take on leadership role, we are not going to transform. The biggest elephant in the room is subconscious bias and racism. In last 1 month, I've given 20 lectures, and not even one place I saw a lot of BME leaders. Everywhere. Unless we get that right, we are not going to transform NHS.
Thank you, sir, for your comments. Any more questions on the floor? There's one right at the back there. If you have a particular question, please address it to the person on the floor.
Yeah, well, it's about the procurement model, and I'm Praveen from Manchester. So my whole thing about the procurement and the thing is, the patients do know best. It shouldn't be at the cost of the clinicians knows better than the patient. That's the underlying tension I can feel in that. And if you're a narrow specialty, if you narrow things, you can be the arbitrator of decisions. But if you look at the patient as a whole, obesity is an illness. So if you shut one door to them, they will go to the next door. So I don't think the health economy should lead to narrow-based, discipline-sensitive or discipline-controlled decisions. You have to take a lighter picture. You have to go into educating, preventative medication, and that's for the society to change. Rather than disease-centered care, it has to be health-centered care. But then coming up with solutions which put the disempowers the patients perhaps, we have to be careful. I would like whatever that model was, I would like the response from them.
Let's put that to our panel, particularly to the 2 people who have so much expertise in medical education and university education.
Who's starting? Medical education. You can start. Oh, thank God.
Okay, so education in general, I've been struck by a lot of the conversations being had today. A few observations from me, really. Usually one person can discharge a patient and about 13 people can stop the discharge. For very good reasons, I'm sure. So my view really is that education, we need to be educating all of our healthcare professionals into taking and being able to take responsibility for patient care. I believe that patients themselves can take responsibility for their long-term conditions too. And I think that more broadly, health education needs to include a lot more about leadership and managing of oneself, but also taking clinical responsibility as well. And a lot of the undergraduate registration programs don't have an awful lot to say about leadership and management.
Well, I entirely agree with that. Can I just say before we say that, this is one of the first conferences I've been to where there's an excitement and a certain degree of wanting to do and wanting to change, which I haven't seen for a long time. So I do hope this is not going to be just more rhetoric and we're going to get on and do some work after it. Several things. Yes, I think one of the things I've always been very keen on is education of the population. To understand what we're doing. Now, gave them choice. Of course, they've got a choice, but if I had I wanted an iron the other day, and I went along to Argos, and there were 76 different irons. So I managed to sort it out. The one had a steam iron, so I wanted a steam iron. There were 12 there, and the difference in cost was between something like 12 and 30 pounds. I'm not an expert. I didn't know how to choose. And I think what we can do with the patients is actually guide them into thinking what is perhaps right. And often the cheapest is the best. It's not the most expensive. Could I just make a comment about the hips? Sorry, who was talking about the hips? Sanjay, yeah, Sanjay. Do you know, I felt so frustrated because 19 years ago, when we started NICE, we were talking about, clinical and cost effectiveness. We then had the model from Sweden where they reduced the number of hip type, the replacements, the actual stuff you were putting in, down to just 3. Now, there was a lot of noise from the surgeons, but they all did what they were told, and the longevity of the replacement increased. Now, here you are talking about, as you said, it was a blurred slide, obviously for effect, but we are now doing so many hips. We cannot all be good at doing all those hips. And somehow, you orthopedic guys have got to get organized together and choose the one that everybody can use. And the cheapest. No, actually, that's a very good analogy.
Thank you. I think, what happened to Charlie? That's only in Wrightington. No. So I think you're absolutely right. There is evidence-based medicine, and patients can't be expected to make a decision on the sort of nuances of various prostheses. That's the surgeon's choice. That's why we spend time training, learning to do how to hip replacements. And the evidence is there. It's not that we are sort of choosing the cheapest implant. We know that those implants, although low in cost, they do very well. And for the bulk of our patients, they do very well. The whole drive is towards patient-reported outcome measures. So now patients will tell us whether it's functioning well. And if they say that this is not functioning well, then we can revisit it. But actually, while there are so many austerity measures, we need to look at the cost. And the company industry does drive it, the new shiny toys. Unfortunately, those 40 prostheses are just the ones that are cemented. So clearly, they can't all be evidence-based. And for about 90% of those, there is no evidence-based to their usage. It's just because somebody's trained to do it, or my boss did it, so I will do it. And I think my mentor, Professor Panister, is here, and he sort of taught us very well to use, it's the surgeon, not the implant necessarily. As long as you use tested implants, it works.
And I believe you actually have a question or comment.
I do. It's not about implants, though. Although I will just say that the Charnley stem doesn't work anymore because it's been changed, so that's why we don't use it. It's medical education and clinical skills that my interest is, and I was going to direct the question to Parag Singhal because he will be starting the new medical school at Glamorgan. But it is apparent that the clinical skills of the emerging British undergraduate now have declined. I know this from my own students, a quarter of a century teaching them. So a simple multiple choice questionnaire, does tennis elbow occur on the lateral side of the elbow, was answered correctly by 70% of students in the 1980s and 27% in the 2000s. And this came across with Don McCready. The emergency doctors don't have the clinical skills to assess the patients who get admitted to hospital, then over-investigated, and it's the same in general practice and it's the same across the board. How can we improve the clinical skills, the hands-on clinical skills of our undergraduates before we let them loose to what is now a very fractured postgraduate training?
I'm going to pass this microphone because I definitely don't know the answer, but as a politician, I hope that one of you is going to tell me the answer.
Well, having taught medical students even longer than you have, there's no doubt I think the clinical skills have gone down rather than up. And I think there's just simple things of taking a good history and a good clinical examination, which would then actually mean you don't have to do all those hundreds of tests that we're doing now and wasting money. I don't know why it's gone down, because we now have clinical skills laboratories. They all go through that. they have to pass a component of their clinical skills to get the OSCE. You know, there are 1 or 2 sections that we actually say you've got to pass, and those are in fact, actually laying your hands on the patient. Now, maybe you could answer it, because you're a very important man.
That sounds like a hospital pass to me.
Well, met before, apparently.
Yeah, we have met before, yeah. Well, look, I agree. I think education in general, we use a lot of simulated practice. There's a lot of congested curricula, and I'm not sure I have the answers, actually. I worry for the pressures in the system. I think we need a lot more of our clinical colleagues to support our trainees and to have the time and the space to be able to guide them, is my overarching view.
Well, Gordon, I'll just probably make one comment. The way we are educating our undergraduates and postgraduates has changed. Medicine is learned on the wards. Surgery is learned in theaters. And what we have done is we have changed the entire landscape of medical education and taken it hands-on to didactic classroom teaching. Medicine can never be learned in classroom. And that's one of the fundamental problems, and educationalists have to think hard and start changing it. The second point being, the more patients you see, more encounters you have, better doctor you will become. Less encounters you have, you will not have the confidence, and then you will rely on investigations to rule the diagnosis.
We have more questions here at the front.
Thank you very much. I think all lectures were so thought-provoking that God knows how many questions are coming to my mind, but I can't ask all those questions. I'm going to say, we all here are from NHS family, okay? NHS is really important to us, so important to us, and we're so grateful to a politician, Bevan, who was the brainchild of the NHS. But believe me, my question is to Thagam actually. Since Bevan, that was the only politician I have respect for. After that, whether it was Winston Churchill, whether it was Margaret Thatcher, whether it was Tony Blair, and now all have conspired to actually destroy the NHS. Me, I think like quite a few people have gone through God knows how many reorganizations. One thing which has really finished or demolished NHS is these repeated reorganizations. Does people know how much Lansley's reform cost the NHS? And we know what NHS reforms are after Lansley. £4 billion were cost to NHS by just and Lansley's reform, were totally useless. We know Labour government again brought on these PFIs. 11 billion spent on PFI actually are costing us anything around 80 billion. So my question is, when would the politicians will take politics out of NHS?
This is a question I get asked a lot, and it's a conundrum for sure, because if you take elected political accountability out of processes which are about life and death, if there is no method of accountability, then you create other problems. So I don't think there's a perfect answer. I agree with you on PFIs, I agree with you on repeated reorganisations, and I think what we need is not to take accountable elected politicians out of this, we just need to try and find ways of encouraging politicians to resist the urge to reorganise everything. Because this goes not just for NHS, it goes for education. Teachers say the same thing to me all the time. You're going to take politics out of teaching. Well, they still want me to raise their pay or to increase school funding. And you still have to there will always be some level of political decision making, even if it's just, we give you all a load of money and off you go and do medical things. We'd still have to decide what that level of money was, and you'd still come to us and say it's not enough or it's too much or you're giving it us in the wrong way. So there would always be some level of political discussion. But I think you've raised something which matters to me hugely, which is about repeated reorganisations. It's one of the battles I think every party has. I have it with my own party. There are members of my own party who want me to commit to an enormous reorganisation of the NHS, and I have said no, because even though I can see what they want to end up with, I can see the sheer volume of waste of money and time that would go into getting there. So I wouldn't take elected politicians out of the equation, because I think it's an important democratic part of the process that you have the right not just to elect people but to unelect us and kick us out when you think we're doing a bad job. but also to make sure that you're making use of the structures where you get to talk to politicians, influence politicians, and a good politician would listen to the experts.
No, I didn't say take politics out of it. What I was saying was stop telling us what to do. Yes,
No.
accountability is very, very important.
No, I think we're probably always going to do that. But we'll try hard to make it a better decision.
I'm certainly enjoying the level of honesty in this room.
Can I just get at her?
Well, you can.
Well, I think I agree with you. We need the politicians there because they're elected, right? But why can't we have informed politicians doing medicine? You know, what I always find is you have a reshuffle, and then suddenly you're doing, I don't know, education one day, and the next day you're doing medicine. And for God's sake, you can't be a world expert. And therefore you arrive there with that urge, you want to change it. And you don't understand it. Answer that one.
I can't. I mean, that's why we have civil servants. Because a good politician will go into a department. I don't know, I've not been a minister, but I've seen some good ones and I've seen some really bad ones. A good politician will go into a new department and will listen to their civil servants and will get the heck out of Whitehall and go and visit the schools if they're education ministers, the hospitals, but not just the hospitals, the public health economy, the GPs, the mental health economy. And I think too many people in politics and in political parties, and I include my own, when they think NHS, they just think hospital and they don't think about health. So I think a good politician, yes, they will get transferred, but we haven't got it. Do you want to go into politics? Because we've only got 9 doctors in the whole of Parliament. So if you only want doctors in Parliament, and I can't make those decisions, I'm not the Prime Minister.
We could just carry this discussion on right here.
Very quick. You actually had a Secretary of State who walked around for 7 years and walked around and said, Parmin, I'll come and see you rather than me going to see him. And then he says, no, we're not going to have any change. The government gets in there 3 days later, £4 billion later, he's changed it.
Okay, I'm going to move this on to questions from the floor. As interesting as it is, I'd like to talk to you both in private later.
Actually, can I make a point? Sorry. So as you can tell from my very, very strong Welsh accent, I used to work in London and I work in Wales. And I think in picking up your point, Wales has a relatively small population, so at 3.1 million, but it has a very, very, very stable philosophical political system. And for my colleagues who also work in Wales, I think we benefit from a relative lack of change. We definitely benefit from the ministers listening very, very carefully. So there's something about scale, I think. And so just to redress the balance in relation to politics, it works really well in Wales, despite what Westminster might want to say.
Welsh Labour government.
And moving on to questions from the floor.
I'm Yogesh Nathwarawal. I'm an orthopedic surgeon from Wales. A lot of good points come out of this excellent presentation, and one of the points was about making awareness of the cost. We're not talking about charging anybody, but when people are aware of the cost, they automatically become prudent. When I look at my NJR report now, I know how much I spend on a prosthesis. What is stopping the NHS for people to be aware? And most of the doctors are here, probably won't realize what is the cost of C-reactive protein. When you order it, if the computer flashes the cost in front of you, when the patient uses the service, a cost just flashes in front of them, I think they will be a little bit more prudent. And the second point I just wanted to make, if I make a brief point, a lot of good things have come out of rationalization of implants and something, but there is a very fine line between rationalization and rationing, and how do we stop that line being crossed? Thank you.
Do you have any comments on that?
I could answer the first one, where I tried to put the label. I mean, we're terrible. You know, I'm in an endoscopy suite, and I say, could I have diazepam or something, midazolam? And a nurse opens a syringe, 10 minutes, far too much, throws it away, and opens another one. And if you had the money on every single thing, as they, I think, do in private practice, you know, they stick it on, we would really suddenly realize how much money we're wasting.
In my local GP surgery, I don't know if it's up at the moment, but for a long time there was a notice up about the cost of a certain drug that was being that patients were demanding, and actually was A, cheaper to buy over the counter at the pharmacy, but B, it was being wasted. And what my local GP did was they put up, this is how many chemotherapy treatments this could pay for, this is how many hip replacements this could pay for. And I believe it had quite a dramatic result. I mean, I actually think there's something in it for patients to have some awareness of what things cost, because I think a lot of patients don't necessarily realise.
Thank you very much. I think we've got about 2 minutes left. It would be
One
wrong of
question,
me
please.
not to.
Yeah.
It would be wrong of me not to answer just one question that was put to me right at the beginning, which is from Sharat. It was, how can the media be more responsible to avoid flashy news and raise unnecessary or unprecedented expectations? It's 14:45, yes, exactly. So, yes, you've got time, yeah, okay. So I feel I have to answer that since I've been sitting up here. I am not speaking on behalf of the BBC because I'm not allowed to, but having worked in the media for a long time, I will agree the media definitely has responsibility in this area to make sure that there aren't incorrect headlines. The media also has a responsibility to hold power to account, to make sure the politicians, to make sure the doctors, to make sure everyone is doing what they should do to serve the public. So if the public aren't happy about something, then it is also the media's job to look into it. And I'd say, having worked on both sides of the fence, having worked in the NHS and having worked in the media, I can see both sides. What really can help, and I'm making this as a plea, is that when people from the NHS get involved, so if you see something and you think, hey, that headline isn't right, or hey, there's a reason that that person didn't get that scan in the 6 weeks, tell us, talk to us, or if we ring, answer, give an explanation, because actually if you give an explanation, that's what the public want to know. They want to know it's because you're making a difficult decision about another patient. They want to know it's because you're putting a system in place, as we've heard today, to make things better, to make sure that not every single test is done. And so then next time they'll expect that. So I say it's a two-way street. Yes, as the media definitely has responsibility, but the doctors, the nurses, the people that work in the NHS do too. I've been told we have a few more minutes for questions, so let's take the ones from the front.
I was waiting for the microphone. I'm in control of the microphone now. I'm the psychiatrist working for Anirudh Bevan Health Board. The spirit of Anirudh Bevan hovers over the NHS all the time. I just want to only comment, again politics, there are a lot of non-political institutions which run very well in this country. One is Queen and Royalty, they do very well without politics. Probably BBC, Judiciary. So in the same way, if National Health Service is removed out of the politics, I think Anirudh Bevan wanted it initially, so that all governments will fight to impress the patients but not the voters. That may be the best way to manage it.
Thank you. I will exercise my choice. Thank you very much. Fantastic discussion, I have to say. Well done to everyone. My question is this, that I'm in that minority, Parag, I'm very sorry to say, where I absolutely disagree with that voting, I'm sorry, Arvind, where it said that we should stop investment in the NHS to stop wastage. No, you can't do that. I know many executive directors will shudder at the thought of no investment coming in, and of course we have to stop duplication and stopping wastage of resource. But you cannot, absolutely cannot invest in an NHS which has been so starved of funds for the last 5 or 7 years. Our GDP is much lower than it has been for a very long time. So I just wanted to make that point. But my point to Parveen was going to be about clinical skills. I absolutely echo what you're saying. I still teach medical students. They are highly intelligent, more intelligent than I was when I was a medical student. They have a real grasp of knowledge, more than I have. But when it comes to clinical skills, I'm sorry, we are doing something wrong. I don't blame them. How can we put it right? And we must blame ourselves for that, surely. Not Kumar and Clark, surely.
No, I think you're, if I may. No, you're absolutely right. I think, thank you. We are doing something wrong. And I just wonder whether it is that they're not on the wards, which I think Parag was making that point. somehow doing clinical skills on a robot, and not a robot, a mannequin, not even a robot, and then you go on to patients, I think you somehow miss that. And, one of the other things was when I was a medical student, I was always on the ward. So if I won't let my medical students say, I'm bored. I'll say, well, go and see a patient. Don't ever tell me you're bored. Go and see another patient. Take a history. And I think it's just now the numbers we've got of medical students versus the number of patients. And patients get fed up. But they're terribly nice and kind to us. But there are too many medical students, and I think we maybe don't pay enough attention to each medical student.
Can I make a comment? Can I make a comment? I think, I don't know, Praveen, you're right. We have lost the balance, I think. We have, we get so many high fidelity simulation, all sort of babies who are like, they go blue and they play all that sort of stuff. But then we lost the actual touch with the patient. And I think we spend too much time on this sort of more skill lab, I know. And I think that balance is, I think, is somewhere we lost it. Thank you.
I'm Dr. Jain. I'm a consultant psychiatrist and I do locums only. So, regarding the cost reduction, I've jotted down the 25 points, but I don't think you will tolerate that. I'll discuss only 2 to 3 points. If somebody is interested, then I can discuss with them. One is that we as a BAPU, I think we are promoting the MTI scheme, and that's very good. And that is training initiative. And I think people come from the abroad, especially Asian countries, and get the opportunity, especially the communication skill. Now, here's a catch. Why it is one-way road? Why it cannot be other way around also? Because the cost reduction are taught at the very basic level in India, where because of the lack of the money, we are taught from the very beginning, take very good history, discuss differential diagnosis, and to that hilt that you minimize the investigation and then you treat the condition with minimal resources. And then, so that because the resources are very less. So, now I came as a consultant directly from India. I was not trained in this country. And we became, we trained in India after reading the books which were written in this country. So I was very amazed that those books which we read about the history taking, that was not implemented during the training. So when I see any case presentation or case conference, so I get shocked that, means there is no structure at all. Nothing, means, and means you can't pass the examination unless you follow that structure, which is written in Professor Kumar and Clark book, which
Thank you, sir, for your comments. So we're running out of time, so if there's just one last question on the floor, thank you.
Thank you. Sorry, my question, it's not exactly, hello, it's not exactly a question. Some information that I would like to share is we worked in America for 1 year. And by that time, we had already worked in NHS for more than 6 years. And when we went to America, the first introduction in the first 2 days was the building that we see is a billing department. And when I went there, I had no idea how the billing or the coding and the costing department in this country. So the first thing they taught me in America is how to do the billing and how to record so that they get more money out of our examination. Okay, and that's the first induction I got. So my kind of a way of looking in here is, if we have a discharge summary in here, perhaps maybe include the cost of that would be something so that the patient and everyone is aware about it.
Some really, really good ideas coming out of the audience and from the panel. Thank you so much. I just want to hand over to Prof. Parag Singhal because he has an announcement to make.
Can I thank you for... Yeah, please. Can I thank all the speakers and the panel for fantastic discussion.
Take taking a cue from what Parveen said, that it shouldn't be a rhetoric alone, who can be a better person to launch the project formally of reducing investigations and pursuing good medical practice? Parveen is mother of medicine, grandmother of medicine, so I invite Parveen on the stage. Dr. Mehta, obviously this whole movement started from BAPIO, Keshav Singhal, NHS Wales is involved, and Eric, you have been the key person for this project. So Parveen, you're...
I thought you were saying great-grandmother.
Right. One more.
Right, well, I'm going to say, one of the things we've been talking about all day is really where should we be doing things. Now, you can get directives from up downwards, but I think you're not going to achieve anything unless it's from the ground up. So you've got to involve everybody in what you do. Once you have ownership, then anything can go, right? And I think I was just fascinated by what Parag told me about the collaboration between 6 different trusts. 6 different trusts, can you imagine? All of them usually fighting. But 6 of them have actually got together and actually worked out how are we going to save money? How are we going to prevent duplication? How are we going to use tests proactively with evidence base and across 5, 6 trusts? And I'm being asked to launch this between, and I can't remember all the trusts, I remember 5 of them, hang on. There's Gloucester, there's Bristol, there is Wales, there is Yeovil. Western.
That's it.
No, you said 6 and you said 5.
2 Bristol.
Oh, 2 Bristol. Well, it's not bad, I only missed 1. That's pretty good.
Well done, well
So
done.
really, I was fascinated to hear about this, and I think this is the sort of good practice we should do across the country. But I also said we wanted evidence before this started, and I want evidence afterwards, and if you can actually prove that to us, then it would be fantastic.
We will do that. Thank you.
Brilliant. So I'm launching that, and congratulations on that.
Thank you.
Can I just say one other thing about this?
Oh.
Okay. Sorry, as I've got 2 microphones in front of me, where's the MWF girl? There she is. Right, come up here, come up here. Now, as you know, Medical Women's Federation, I had the great honor of being the president for the last 2 years, in its 100th year. So women have come a long way from Elizabeth Garrett Anderson and even, what was his name? The man, Barry, James Barry, who was the first female doctor, but spent all her life as a man, and they only discovered she was a woman when he died. Sorry, she died, because she'd been dressed, and she was in the army. Can you imagine being in the army as the only woman, and she managed to die? So she was the first. Elizabeth Blackwell, who in fact is a Bristol person, isn't it? Because I'm giving this Elizabeth Blackwell, are you coming to it? I'm going to lecture fairly shortly. And then Elizabeth Garrett Anderson. So I'm going to tell you about the next MWF meeting on November the 16th. Boys, please come as well. We have been quite open. I wanted to get boys in, we can't do that. But it's a great meeting. It's going to be in London. We've got Sally Davis, CMO, all sorts of wonderful people. And you're going to say...
Yeah, I'd also like everyone, please, to save the date because our spring conference will be here in Bristol. So the date is the 17th of May, and men welcome as well. It would be great to have you all involved. Many thanks.
Brilliant.
Thank you.
Thank you.
Ladies and gentlemen,
that's nice.
Parag said that you are mother of medicine. She doesn't look like mother, is she?
No, grandmother is what he said. And then somebody said great-grandmother, so...
No. I think it's absolutely right. You are one of our role models. And thank you very much. I just wanted to say that BAPIO doesn't believe in just talking and having meetings but doing things. And this project, this is one of the several initiatives that BAPIO has taken, and Parag is leading this one, reducing investigation. This is it. We are talking about affordability and how we can reduce the expenditures in NHS. So BAPIO is taking lead in this, and Ma'am, Mother of Medicine, thank you very much for launching. Thank you.